Melanoma staging, classification and prognostic assessment. Melanoma staging is a critical classification system that determines disease extent and guides treatment decisions. Understanding the staging framework helps clinicians stratify risk and establish appropriate therapeutic strategies. Understanding melanoma staging. Melanoma staging represents a systematic approach to evaluating the extent and severity of malignant melanoma at the time of diagnosis. This classification system provides clinicians with standardized criteria to assess how far the disease has progressed, predict patient outcomes, and select appropriate treatment modalities. The staging process involves analyzing multiple tumor characteristics and determining the presence or absence of regional and distant disease spread. By establishing a common language among healthcare providers, staging systems enable consistent communication about disease severity and facilitate comparison of treatment outcomes across different populations and institutions. The TNM staging system for melanoma. The TNM classification has become the internationally recognized framework for melanoma staging, where T represents the primary tumor characteristics, N indicates regional lymph node involvement, and M describes the presence of distant metastases. This systematic approach allows clinicians to combine information about tumor depth, ulceration status, mitotic rate, and lymphocytic infiltration to precisely categorize the T stage. The N component evaluates whether cancer cells have spread to nearby lymph nodes and quantifies the number of involved nodes and the extent of involvement. The M component determines whether the disease has disseminated to distant organs such as the lungs, liver, brain, or bones. Together, these three parameters create a comprehensive assessment that guides prognostic predictions and therapeutic recommendations. Primary tumor assessment. The T-stage evaluation begins with measurement of Breslow thickness, which represents the vertical measurement of the tumor in millimeters from the granular layer of the epidermis to the deepest invasive component. This measurement serves as one of the most important prognostic factors in melanoma, as greater thickness correlates strongly with increased risk of metastasis and death. Beyond thickness measurement, pathologists assess whether the lesion has broken through the epidermis, ulceration, which significantly impacts prognosis and stage assignment. The mitotic rate, defined as the number of dividing cells per square millimeter, provides additional prognostic information and influences staging decisions, particularly in thinner melanomas. Key points: T1 melanomas measure 1 millimeter or less in thickness and may be further subdivided based on ulceration and mitotic rate. T2 melanomas range from 1.01 to 2.0 millimeters and are categorized by presence or absence of ulceration. T3 melanomas span 2.01 to 4.0 millimeters in depth and incorporate ulceration status into staging. T4 melanomas exceed 4.0 millimeters in thickness and carry the highest risk among primary tumor classifications. Regional lymph node involvement. Regional lymph node staging, N component, assesses the extent of cancer spread to lymph nodes in the drainage basin nearest to the primary melanoma. This evaluation includes determining the number of involved nodes, the total tumor burden within nodes, and whether involvement is detected clinically or only microscopically through pathological examination. Sentinel lymph node biopsy has become a standard procedure in melanoma evaluation, particularly for intermediate and thick lesions, as it provides accurate staging information that influences treatment decisions and prognostic assessment. The presence of micrometastases, cancer deposits visible only under microscopic examination, carries different prognostic significance than macrometastases, which are clinically apparent or larger than 0.1 millimeters. Key points: N0 indicates no regional lymph node involvement, representing the most favorable lymph node status. N1 represents involvement of a single regional lymph node with varying implications based on tumor burden size. N2 indicates either 2 to 3 nodes involved or 1 node with in-transit metastases. N3 reflects extensive nodal involvement with 4 or more nodes or matted/confluent nodal disease. Distant metastatic disease assessment. The M component of melanoma staging identifies whether the disease has spread beyond the primary site and regional lymph nodes to distant organs. Patients with detectable distant metastases face a fundamentally different prognosis compared to those with locoregional disease confined to the skin and regional lymph nodes. Distant metastases may appear in virtually any organ system, though the lungs, liver, brain, and bone represent common sites of spread. The location and number of metastatic lesions significantly influence survival estimates and determine eligibility for various treatment approaches. Modern surveillance techniques, including imaging studies and laboratory markers, help identify distant metastases that may not be apparent on clinical examination alone. Key points: M0 designates the absence of distant metastases and represents the most favorable M category. M1A encompasses metastases detected in skin, subcutaneous tissue, or distant lymph nodes. M1B indicates lung metastases, which historically carried a somewhat better prognosis than other visceral sites. M1C includes metastases to the brain, bone, or other visceral organs beyond the lungs. Overall stage grouping. The combination of T, N, and M categories generates an overall stage grouping that ranges from stage 0 through stage 4. Stage 0 melanomas, also termed melanoma in situ, have not invaded the dermis and carry an excellent prognosis with appropriate surgical management. Stages 1 and 2 represent locoregional disease without lymph node involvement, distinguished primarily by primary tumor thickness and ulceration characteristics. Stage 3 encompasses melanomas with regional lymph node involvement or in-transit metastases, reflecting a more advanced locoregional presentation. Stage 4 melanomas demonstrate distant metastatic spread and represent the most advanced disease state requiring systemic therapy approaches. Prognostic factors beyond TNM. While the TNM system provides the foundation for melanoma staging, additional factors contribute important prognostic information and may influence treatment recommendations. The presence of ulceration consistently predicts worse outcomes within each TNM category, effectively elevating prognosis to a higher stage. Lymphocytic infiltration patterns, particularly brisk lymphocytic response at the base of the tumor, may confer improved prognosis compared to tumors with minimal immune infiltration. Genetic testing for BRAF V600 mutations and other molecular alterations increasingly guides treatment selection for advanced melanomas, though these markers also provide prognostic insights. Patient factors including age, performance status, and the presence of comorbid conditions complement TNM staging in determining overall management approach and expected outcomes. Clinical application and treatment selection. Melanoma staging directly informs treatment strategy selection across all disease states. Patients with stage 0 and early stage I disease typically receive surgical excision with appropriate margins as curative intent therapy. Intermediate stage I and stage 2 melanomas may warrant sentinel lymph node biopsy to identify occult nodal involvement that would upgrade stage and alter subsequent management. Advanced stage 3 and 4 patients require comprehensive systemic assessment and consideration of immune checkpoint inhibitors, targeted therapy agents, chemotherapy, or combination approaches depending on molecular characteristics and disease burden. The staging information also guides surveillance strategies, with higher stage patients requiring more intensive monitoring for recurrence or metastatic progression. Adjuvant therapy considerations. Stage-based treatment recommendations increasingly incorporate adjuvant therapy for patients at high risk of recurrence following surgery. Patients with stage 3 disease and adequate functional status may benefit from immune checkpoint inhibitor therapy following surgical lymph node dissection to reduce recurrence risk and improve survival. Targeted therapy approaches using BRAF and MEK inhibitors represent another adjuvant option for patients with BRAF V600 mutated advanced melanomas. Stage 2 patients with high-risk features, particularly those with thick ulcerated lesions, may also be candidates for adjuvant systemic therapy based on individual risk stratification. The stage assignment therefore becomes instrumental in identifying patients most likely to benefit from intensive multimodal approaches rather than surgery alone. Recurrent and advanced disease staging. Patients who develop recurrent melanoma following initial treatment require restaging to determine the new extent of disease and guide additional therapeutic interventions. In-transit metastases, cancer deposits appearing between the primary site and regional lymph nodes, represent a distinct category requiring specialized management approaches. Locoregional recurrence patterns differ from distant metastatic spread in terms of treatment feasibility and prognosis, with some locoregional recurrences amenable to surgical salvage. The time interval between initial treatment and recurrence provides prognostic information, with longer disease-free intervals generally suggesting more favorable outcomes compared to rapid recurrence. Restaging evaluation should mirror the thoroughness of initial staging to identify all sites of disease before determining salvage or palliative treatment strategies. Conclusion and clinical significance. Melanoma staging represents an essential framework that translates pathological findings and clinical assessment into standardized categories predictive of disease behavior and patient outcomes. The TNM system, combined with assessment of additional prognostic factors, enables clinicians to stratify patients into groups with distinct survival expectations and therapeutic options. Regular updates to staging classifications reflect evolving understanding of melanoma biology and improved recognition of factors influencing prognosis. Accurate staging requires multidisciplinary collaboration among dermatologists, pathologists, surgeons, and medical oncologists to ensure comprehensive evaluation and appropriate application of staging criteria. For patients and clinicians alike, understanding melanoma staging provides a common foundation for discussing disease status, establishing realistic prognostic expectations, and selecting therapies most likely to optimize outcomes based on individual disease characteristics and circumstances. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.